asymptomatic group, or in the intermediate group that will develop temporarily thrombocytopenia and hepatosplenomegaly and can be followed up postnatally without doing in utero intervention. The question is, should we actually be treating patients with cytomegalovirus or toxoplasma with antiretroviral treatment or antitoxoplasma treatment? And the point is really catching those patients when they just develop the seroconversion. And actually it's really difficult to do that because the cytomegalovirus is an asymptomatic infection in most cases. It's like an influenza kind of presentation, and as well the toxoplasma. And the point is, if you see patients who have already developed fetal damage, then it's too late to do anything at all. But I really find that a lot of physicians are prescribing lots of antiretroviral, lots of antiviral treatment for CMV patients who have had previous CMV infections in a previous pregnancy, or anti-toxoplasma treatment because they think they're actually reducing fecal-maternal transmission, which is not really the case. The problem we face with the seroconversion as well with cytomegalovirus is the issue about the IgM. The IgM and cytomegalovirus can actually last in the circulation for a bit longer, similar to toxoplasma, causing more of a gray zone or a gray dilemma. And we do what we call a avidity test to say whether it's aggressive antibodies, so it's a recent infection, or less aggressive antibodies, so it's not a very recent infection. But to be honest, I don't really do those because if I see features on ultrasound to say the fetus has been affected, it's a hopeless case. This baby will have severe neonatal sequelae. If they don't develop it, then it's either in the intermediate group or in the asymptomatic group. And I really find it difficult to justify therapy or to justify actually biopsying those fetus to confirm whether they have the infection or not, because otherwise I'll be the person transmitting the infection by breaking the placental barrier that has been defensive against the virus from the start. What about parvovirus B19? Actually, this is a very, very important virus for us because it's a droplet infection, it's a DNA virus similar to the others, and it has a high rate of transmission, 33% rate of transmission. Mothers usually present with asymptomatic features or features like influenza or sheep disease, which is not really a common presentation. And usually what they present with is they have been exposed to a child who have developed parvovirus in a nursery and they're concerned about the sequelae for the mother, or they come to us with severe non-immune hydroxyphthalate. And the good thing about this virus is that that's the only condition where the baby will have severe ascites, severe pleural effusion, severe anemia, and if we do treat them by intrauterine fetal transfusion, they will recover totally and will have a normal outcome. In comparison to, in best hands with immune hydrox, with Rh disease, we have a 70 to 80% survival here in our cases and even abroad. So that's a very important virus to actually pick up because if we know what happened, if we know that this mother has been seroconverted to parvovirus and the cause of the non-immune hydroxyphthalate is anemia caused by the temporary suppression of the bone marrow and the temporary myocarditis that happens, if we transfuse them in utero, they totally recover with a very normal outcome at the end. We always look for features of hydrox in the sense that we can tell whether the baby has developed hydrox due to just an infection or whether the hydrox is caused by anemia. And we can tell that the baby is anemic because we will find cardiomegaly for sure. The heart is definitely markedly dilated in those cases, not obviously in the one I'm showing. This is just a congenital infection kind of case. And as well, we can tell by checking for the middle cerebral artery velocity. We can tell the baby when they are anemic, the quantity of the red cell mass to the plasma is reduced, so the blood is thinner, so the blood flows quicker than normal. So we can actually tell that the baby is anemic, and if we pick them up early, even if they have hydropic with parvovirus, they will actually have a very good outcome by 1 or 2 settings of intrauterine transfusion. What about congenital rubella? Well, luckily now, obviously, because of the advance of new physicians in the neonatal sector, we've actually hardly see any more of congenital rubella because of the vaccination. The problem as well is the incidence that it causes about 20% risk of transmission, and the defects are so severe. If it happens, they are so severe: congenital cataract, congenital heart defects, sensory neuronal hearing loss, and severe mental retardation, particularly if it happens before 12 weeks. And if it happens between 12 and 16 weeks, the main issue is deafness. And actually, rubella for us is not a problem because we always screen all pregnant women for IgG for rubella to make sure that they're immune for rubella at the start of the pregnancy and to see whether they are not immune. In that case, we know that they're seronegative from the start. If they develop seroconversion into the pregnancy early, then we know that they have a 20% risk of fetal-maternal transmission. But in those cases, I still don't biopsy them because if they develop congenital rubella, then I would definitely see it at 12 to 14 weeks. I would see major defects in the fetus, major cardiac defects, major affection of the CNS. So I will usually pick it up. If they develop it between 12 to 16 weeks, that's a difficult one because the baby will not show issues, but the baby will still have a risk of 20% developing deafness, and that's a difficult counseling point. But if we think of all those infections, it's always easy for us to just insert a needle, take a biopsy, whether we take it from the amniotic fluid at 16 weeks, whether we take it from the placenta at 12 weeks, and we can actually do PCR analysis since it's all molecular now to see whether we have congenital rubella, congenital cytoplasma, toxoplasma, or cytomegalovirus when we're so concerned about the risk of transmission. What about HIV? Well, luckily we don't see a lot of those cases, but we still see some. It has a low prevalence in Europe in general, but a very high prevalence obviously in Africa. And the issue about it is really whether we can reduce the risk of fetal-maternal transmission. The risk of fetal-maternal transmission is high in patients who breastfeed and who don't receive retroviral treatment. But if you give them retroviral treatment, if you do elective cesarean sections for them so that no contact between the maternal and fetal blood happens, and as well if they are on multiple agent antiretroviral treatment, we can reduce this risk of transmission to under 2%. So from 20% to under 2%, which is actually a big advance. And as well, obviously they need intensive sort of therapy for those mothers because they really need specialist personnel who can handle them and who can handle the impact of the immune deficiency. Let me just conclude. What about the TORCH test? Should we be doing TORCH? Well, we don't do TORCH routinely now. We don't offer TORCH as part of pregnancy screening, and I don't recommend to do that because I would only do TORCH when I do an ultrasound and find features to say that the baby is severely destroyed by what looks like an infecting agent, and I just want to know which one of those to confirm my diagnosis. But it's really not an important test as part of the pregnancy screening. It's not an important test as part of screening or diagnosing recurrent miscarriage. And as well, it will not really change the way we manage patients if the baby is already damaged, CNS or otherwise, by the infected age. In summary, well, fetal infections can be so severe if they happen in the first trimester, particularly at the time of organogenesis. The TORCH test is performed when there is an ultrasound sign to suggest fetal infection, confirm the diagnosis, and needs accurate interpretation, because if you don't do the IgM, then what's the point of doing the IgG? The only value of toxoplasmosis treatment is to reduce fetal infection rate in patients with proven seroconversion in the current pregnancy without evidence of fetal damage. And if a patient is exposed to infection and has shown seroconversion in pregnancy, we need really to see them in specialist centers to actually see what we can do for further management and to give them the proper care. Thank you very much.
Thank you very much, Dr. Ahmed. I think it's a very important point in our practice regarding the fetal medicine and infection. Thank you so much.
It's my pleasure to present Professor Sumaya Al-Khammari, head of the Clinical Pathology Department in Fayoum Faculty of Medicine. Professor Sumaya is a national and international figure in clinical and laboratory hematology, and she is an eminent founding member of the National Egyptian Committee for Treatment of Gaucher disease, and she is going to present her experience in prenatal diagnosis of Gaucher disease in Egypt.
Thank you so much, Professor Azza, for this presentation for me. It's too much for me. Thanks so much. And thank you, Dr. Laila. And thank you, of course, my eminent professor, Dr. Bishlawi. This is the 14th meeting of our society. Actually, I remember exactly in 1999, in 19th of October, the first time we do in Atfal Aborish, we do a prenatal diagnosis. We start by thalassemia, and we invite Mary Vitrio from London College University and Dr. Eric Genot. You remember, of course, yes. Now that the first time, and when we are speaking about how to do prenatal diagnosis, it was fantastic. Then after 2 years, actually, I start in Fayoum University to do prenatal diagnosis. I start by thalassemia, of course. We have a lot of cases of thalassemia. And in 2007, we start to do prenatal diagnosis also for Gaucher. This is very briefly. Please. Gaucher disease is the most prevalent genetic lysosomal storage disease. It's an autosomal recessive disease. It was described by, of course, all of you know, by Philippe Boucher in 1882. It's called severe deficiency of glucocerebrosidase, the enzymatic activity, which is accumulated in a large quantity of glycolipid and cerebroglucocerebrosidase within the lysosomal phagocytic monocyte macrophage. Gaucher disease classified into three. I will run quickly, Dr. Amal, as you said. We have three types, all you know, type 1, type 2, and type 3. Type 1 is the most common chronic non-neuropathic type found in adults, especially in Jewish population. It's involved viscera, blood-forming tissue. Most of these patients develop massive splenomegaly, anemia, and bleeding tendency. Type 2, the infantile neuropathic type, it's rarer than type 1, appears by 6 months of age. It doesn't have predominance in Jewish, and the neurological manifestation of splenomegaly, pulmonary, and the body affection are the most presenting symptoms. Type 3, as you know, it begins at a later childhood or adolescence. It includes heterogeneous group of patients with signs of chronic adult type obtained from slowly progressive neurological manifestation. Prenatal diagnosis of Gaucher, as I said before, we started in 2007. Actually, it's available now in many centers, I think so. This allows parents to consider termination or prepare themselves for the enzyme replacement. As Professor Abdelgawad said, we are a member of the International Gaucher, of course, Dr. Amal and Dr. Azza, and from other universities, from Alexandria, Asyut, Mansoura, and Dr. Zazig, of course, yeah. We are a lot of many universities, and we are a part of the International Gaucher Registry, and we have a 2 meetings per year, actually with our colleagues from Washington, and this registry offer for us, for our patients, the ceridase enzymes. And now we diagnose or starting prenatal diagnosis about, we have, Dr. Bishawi, we have about 130, for total number of all the university. 230, and about 15 patients, from 12 to 15 patients born per year. So we started making this prenatal diagnosis since 2007. As I said, it's available in many centers. The identification of the carrier can be done by enzyme assay and molecular studies. Carrier detection and prenatal diagnosis for their families or for their parents with family history of Gaucher disease should be offered in conjunction with the genetic counseling. The aim of this study is to assess prenatal genotype of the Gaucher disease in Egyptian pregnant mothers who have 1 child or sometimes 2 child or 3rd child Gaucher disease, and most of them now on this registry, and they have the ceridase enzyme replacement. Many of them, of course, in Fayoum. The registry or affected families was assessed through the hematology outpatient clinic of New Children's Hospital, Cairo University, and neuropediatric unit in Fayoum University. A Gaucher registry is now maintained, as I said. I'm not speaking anymore about this registry. Actually, this registry in help with Project Hope. We have Project Hope who offer for us the price, besides the company, of course, the price of the ceridase enzyme. Do you know that the vial of, how many grams, Dr. Amal?
100.
No.
1 gram by $3.
But 1 gram by 2. About the vial, $1,400. we give about 60, advanced of course, we give replacement about 60 to 100 gram per kg per weight. Currently, there is around, I said 130, and Dr. Bishlawi said that now they are 230. And as I said, 12 to 15 new cases added to this registry per year. The University Research Ethics Committee, which is a member of the NREC, was informed of this study, of course. The present study included 42 pregnant women with previous children with Gaucher disease. They are diagnosed by the enzyme assay of beta-glucosidase activity in peripheral leukocytes, genotype by molecular diagnosis by PCR. After details counseling, informed written consent was received from the studied couples in Arabic. Detailed description of the procedure, amniocentesis or chorionic villus CVS. The time interval between the procedure and the availability of the record and risk were explained to the couple at risk. All the pregnant women were subjected to complete physical and systemic examination, comprehensive family study, including consanguinity, affected sibling, and similar conditions in the family were taken. According to the age of the presentation, 30 mothers underwent CVS and 10 to 12 weeks of pregnancy. And 12 mothers went amniocentesis from 14 to 16 weeks. As we all know, the Sharia said that we can make abortion before the 120 days without any harm to the mother or to the mother. For the CVS, a 22-gauge single needle was used and passed through the placenta in order to aspirate the chorionic villus samples. The aspirated chorionic was examined under fetal, indirect microscopy to exclude fetal maternal and to separate the fetal maternal from the fetal from the maternal sample. All the women were shown the fetus and the fetal heart sound, of course. All the women were asked to report immediately about any pain, bleeding, or any concern. Women returned back after 5 to 7 days to perform an ultrasound and follow-up. The methodology starts after we separate the fetal from the maternal sample. We do DNA isolation and PCR amplification and hybridization. The methodology we use is covers the 8 common GPA mutation, which is this common mutation. As I said, the most common mutation is the L44P. And we have 2 cases also, heterozygous for G409H and homozygous case of N370S. The mean age of the studied group was 23.6 years. Positive consanguinity was present in 38–90% of cases. First cousin consanguinity was in 71%, and remote consanguinity was in 8 or 19%. Negative consanguinity was present only in 9.5%. This is the table for the frequency of consanguinity. And the median gestational age was 13, carrying out the procedure was 13.8. There are no fetal losses related to the prenatal diagnosis procedure. However, mild bleeding was encountered in 2 cases only. 24 fetuses proved to be carrier, it means trait, and the other 18 proved to be affected. 5 women out of the 18 who were pregnant in affected fetuses decided to terminate their pregnancy. The remaining women decided to continue, and the babies were born with Gaucher disease, and they are now on 3 days replacement. Genotype analysis of the studied individual is shown in the next tables. Analysis revealed 15 fetuses were homozygous L44P. All the fetuses homozygous L44P means that the two alleles are L44P. 24 pregnant women had a carrier fetus which are all heterozygous L44P. So this is a case, these are homogeneous cases, 15 cases, and this is the double heterozygous, as I said, 2 cases, L44P, G409H, and 1 case only, N370, and the carrier cases, as I said, heterozygous for the L44P. This is the frequency of the allele, and this is the state. This is by PCR. I want to stress here about this is done by PCR, and at the end of my talk, I will say that this is not enough until now, because I discovered as we started in thalassemia, we do by PCR, and then we do by sequencing. So the 5 or 15% underdiagnosed by PCR, we diagnosed by the sequencer. So in Mansoura University now, they started to do the DNA sequencing in Gaucher also, not thalassemia. And they discovered a new mutation, which is 7336 mutation, which is very new mutation all over the world in Gaucher. They found it in Mansoura University. So from now there, I will do by DNA sequencing. Maybe we have another cases like this mutation. The most common mutation, as we said, is L44P homozygous, followed by double heterozygous L44P, G409H, and the homozygous for N370 is only 5.6%. Only 1 case. As we said, the allele frequency, the L44B of the standard chromosomes, about 97.1, and the G409 is about 4.8%, and the N370 2.4%. As Professor Bishlawi did and published international in 2006, it's 14 out of 22 patients were homozygous or compound heterozygous for L44P and G409H mutation. Butler also in 1993 they found the frequency of N370 L44B 84 GG, and they never found in Egypt, and IVS2+1. I found it before in another study, but not prenatal diagnosis, study for children with Gaucher. This is the one I want to stress about, El Morsi, not our president. He worked in Mansoura University. I saw it for the first time, our president. Recently, more than 20 mutations have been found in patients with Gaucher disease, where novel mutations are continuously detected, adding to the expanding of Gaucher mutation. So I will, from now then, I will do by DNA sequencing, applied by system, genetic analyzer 310. As said Bishlawi before said, 2/3 of the patients were from contiguous PDD, وانا عملت برضه دراسه قبل كده كانت 80% of the cases were from contiguous parents and 30% of them. All the cases with the genotype L44P and N370 in this study were from contiguous parents. Although 24 cases were carrier for Gaucher disease, heterogeneous L44P mutation, only 4 cases had a negative consanguinity. So this study confirmed about that 100% of our affected cases were from consanguous BDG, while 16.6% of the carrier state was from non-consanguous marriage. This is done before in another study, the high frequency of positive consanguinity and the mode of disease inheritance drives attention to the importance of genetic counseling and prenatal diagnosis of the disease. And what this happened, we already do starting from 2007 prenatal diagnosis. There's another reference for another mutation, not in ours. We have only one case of this N37S. And I think this is the most common mutation found in our study was the L44P homozygous. The high frequency of positive consanguinity and the mode of inheritance drives the attention to the importance of genetic counseling and prenatal diagnosis of Duchenne disease among the high-risk group in Egypt. Recommendation, of course, we do another, every case seeking for diagnosis or prenatal diagnosis we ask for. And thanks so much, and thank my colleague here, Dr. Hadir Abdel Ghaffar, Dr. Khalid Eid, Dr. Madi Abouab, Dr. Wael Ragab, Dr. Wael Saleh, and Dr. Sahar Baradei, all of them working in this work. Thanks so much.
Thank you very much, Professor Gawhari. The L414 mutation عشان it is the most common mutation in Egypt عشان كده احنا عندنا lot of type B patients is the predominant phenotype. Thank you, Shams. حضرتك يعني شرفتينا وعملت لنا good awareness للناس كلها بالمشاكل. Thank you.
I'm going to start now حقيقي بقى الكوفي بريك. Please here 2 و5 بالظبط.
1 و5 دكتورة.
1 و5 كمان.
In Thalassemia, we will have 5 talks, and all will be on the endocrine complication in Thalassemia. We'll start with the first talk, the gross disorder in Thalassemia. It will be presented by Professor Ashraf Suleiman. Professor Suleiman is a professor of pediatric endocrinology in Doha, in Ahmad Hospital in Doha, and he is also professor in the University of Alexandria. So please, Dr. Ashraf.
Hello.
I think the time for each lecture will be 20 minutes.
Okay. Thank you very much, Chairperson, and it is a pleasure to come and present some of the endocrine problems in thalassemia. And my first talk today is about growth in thalassemic patients. As you all know, thalassemic patients, the mortality is improving too much, and still the morbidity coming from endocrine problem is very common in these patients. And the quality of life depends on prevention and treatment of these endocrine problems. My first talk is about growth and growth problems in thalassemic patients. And we have many questions to answer. Do patients with thalassemia have significant growth problems interfering with their life? And what is the magnitude of this growth problem? As we all know, the phases of growth we can divide into 3 important phases: infantile phase, and childhood phase, and pubertal phase. The infantile phase is a rapid phase and depends on the nutrition and not growth hormone dependent. The childhood phase is a little bit slow and steady, and it depends on growth hormone and IGF-1, vitamin C. And the pubertal growth spurts depend on the growth hormone, IGF-1, as well as steroid secretion. And to answer the first question, the prevalence of growth and pubertal abnormalities in patients with thalassemia major, we have a lot of surveys coming from different countries with the same conclusion. From Cyprus, 35% they have growth delay and 30% have hypogonadism. Greece, 30% growth delay, 42% hypogonadism. Italy, 49% they have hypogonadism. In Egypt, different reports from different areas, between 40 and 60% they have growth delay and 40 to 70% hypogonadism. Romania, 50% and 77%. The TIF report is 30%, 31% growth delay and 40% hypogonadism. This concludes that there is a big problem of growth and pubertal delay in these patients. This is our study lately done in Qatar, and we have 62%. They have a high standard deviation score below -2, so they are very short with growth, with hypogonadism of 46%. This is back 10 years back in Alexandria. We did a survey and we found that in 120 patients, they have 50% have a high standard deviation score below -2, and they have very slow growth velocity below -1. So in conclusion, thalassemic patients, they have a lot of growth delay as well as lack of pubescent changes. What is the growth pattern of these patients and the stage of growth affected in these patients? If we study the growth pattern of patients with thalassemia, we can find very easy that they are slow growers, but they, during the late childhood and pubertal age period, they deviate down to a lower level. And this is the growth velocity curve that shows the drop of their growth velocity during the late childhood period and the very attenuated and slow and late part of their growth during puberty. So we recognize that these patients have the significant growth problem occurs late in childhood and during puberty. They have also disturbed upper to lower segment because of short trunk due to vertebral pathology. The time of growth abnormalities that we recognize is late childhood and pubertal, and we know that the late childhood period, the growth depends on growth hormone IGF-1, nutrition, and during the pubertal growth spurt, which is attenuated in these patients, it is nutrition and IGF-1 growth hormone and sexy steroids. The high prevalence of short stature is coming from all over the world, different reports. But what is the effect of intensive chelation therapy on growth? Actually, if you start early, there is a positive, very positive effect on linear growth, and 80%, not 100%, but 80% of children with thalassemia can attain normal adult size. The reported endocrine abnormalities are many in these patients, including growth hormone deficiency, IGF-1 deficiency, hypogonadism, thyroid dysfunction, impaired glucose tolerance, and insulin-dependent diabetes or diabetes, hypoparathyroidism, and sometimes, rarely, cortisol deficiency. We'll start with the studies on growth hormone and IGF-1 in thalassemia, and the studies start with growth hormone response to provocation, spontaneous growth hormone secretion in these patients, IGF-1 secretion, and IGF-1 generation. as we all know, the hypothalamus is controlling the pituitary release of growth hormone, and the growth hormone goes to the liver and secretes IGF-1 in the liver as well as directly in the growth plate to induce growth. So the growth is dependent on the IGF-1 of systemic IGF-1 as well as the effect of growth hormone directly on the IGF-1 released by the chondrocytes. The first question, do patients with thalassemia, short patients with thalassemia have growth hormone deficiency? And this is the report from different countries. Actually, in Doha, we have 45% prevalence of growth hormone deficiency. In Alexandria, we did the survey, and it's 40%. In Cairo, they reported 33%. Athens, Greece, 38%. Turkey, 40%. And this is as a group of patients, we have this red line represent the growth hormone response after clonidine stimulation and after glucagon stimulation with the in response in comparison with growth hormone deficient patients and with normal variant short stature, and you can recognize easily that these patients they have subnormal response to provocation with both clonidine and glucagon and other stimulants actually reported in the literature. So short thalassemia patients, they might have abnormal growth hormone response to provocation, but those with normal growth hormone response to provocation, do they secrete normal growth hormone spontaneously without chemical provocation? We studied the nocturnal release of growth hormone in these patients, and we compared this is the normal secretion, this is the control, and to the left side is the patients. And you will find that the pulse of growth hormone, spontaneous growth hormone overnight is reduced, both the peak and the amount of growth hormone release is very deficient in these patients. Some of them, they don't release at all growth hormone at night. These patients responded very well to chemical stimulation by clonidine and glucagon. So they have neurosecretory dysfunction or pulse of growth hormone. They reduced peak and diminished duration of growth hormone secretion, spontaneous growth hormone secretion at night. So there is a high incidence of growth hormone neurosecretory dysfunction in short patients with growth hormone with thalassemia. Do they secrete normal IGF-1? As I told you, the IGF-1 is secreted under the influence of growth hormone by the liver and as well as in the growth plate. And this is the response of thalassemia patients to the IGF-1, the baseline IGF-1 is reduced compared to normal. And the low IGF-1, they have high prevalence of IGF-1 deficiency, ranging from 50 to 85% from all over the reports coming from the world. And this might be due to defective growth hormone secretion, or even with normal growth hormone response, they have low IGF-1 secretion because of the neurosecretory dysfunction. We followed up the IGF-1 secretion by age, and I'll show you the curve. This is the normal, this is the average curve for IGF-1 for children and adolescents. And the black line is the IGF-1 during the age from 4 to 19. And you can recognize very easily that these patients, since early childhood, they are secreting very low IGF-1, especially during the pubertal years of growth. So the next question to be answered: if we inject them with growth hormone, do they secrete IGF-1 to the normal level? So we injected these patients with growth hormone to see for 3 days, and we measured this is, I should explain. This is the IGF-1 secretion I told you all over the years of childhood and puberty. It's very low. And especially low during the pubertal age between 13 and 19. And this is corresponding to the growth curve. They dropped their centiles during their growth curve, especially during the late childhood and pubertal age group. So, do they generate IGF-1 if we inject them with growth hormone? The answer is no. If we inject the patients with thalassemia with growth hormone, they do not release a lot of IGF-1. They have a partial resistance to growth hormone. And not only IGF-1, but IGF-1 binding protein 3, they have lower IGF-1 binding protein 3 baseline as well as after stimulation with growth hormone. So to conclude about growth hormone and IGF-1, children with thalassemia and adolescents, they have high incidence of growth hormone deficiency and neurosecretory dysfunction of growth hormone release. They have low IGF-1 and binding protein 3. They have decreased IGF-1 synthesis after growth hormone secretion. About 40% of them have clear growth hormone deficiency, and about 40% they have abnormal IGF-1 secretion after growth hormone. So the next question: does correction of anemia increase secretion of IGF-1 in thalassemia children with low IGF-1? And does it improve the response of IGF-1 to exogenous growth hormone? So when we inject our patients with, we increase their hemoglobin, does it increase the IGF-1 and consequently, does it increase growth? And this is the answer. This is basal IGF-1 before blood transfusion. And this is basal IGF-1 after blood transfusion. Significant increase of IGF-1 only not by giving growth hormone, but by injecting red cells. And the hemoglobin concentration correlated very well with the IGF-1. So you increase the hemoglobin, the IGF-1 increases. So IGF-1 levels increase significantly with correction of anemia. And growth hormone injection increased the IGF-1 significantly in thalassemia patients, but not to the level of normal patients with growth hormone deficiency. So they have a partial growth hormone resistance. And the peak IGF-1 response to growth hormone injection did not differ before versus after blood transfusion. So what is the effect of pubertal delay on growth and IGF-1 secretion? As we know, thalassemic boys and girls, they have high incidence of pubertal delay and sometimes failure of puberty due to gonadotrophin deficiency. And the deprivation of growth hormone and the IGF-1 that was clear in the surveys, it leads to delay of the timely onset of puberty in these patients. It slows the pace of pubertal maturation and attenuates the phallic growth in boys with thalassemia. and reduce the other adult testicular size. And this is my next lecture. Actually, they don't secrete gonadotrophins overnight compared to normal. They have flat curves. So what is the effect of nutrition on these patients? And we know that patients with thalassemia during our survey, they have low subcutaneous fat thickness, low muscle mass, and they have low BMI compared to normal children. And the nutrition is very important in growth, in all stages of growth. So we studied, and others studied, the protein, calorie, and zinc status, vitamin D status in these patients. And this is our study. When we increase the caloric intake of these patients over a period of 3 to 6 months, this will increase not only the weight, but also the IGF-1. So the IGF-1 increases only by improving the hemoglobin of the patient and improving the nutrition of the patient. And also we have screened our patients with to vitamin D, and we found that about 50% of them, they have vitamin D deficiency, and the reports from other studies actually showed vitamin D deficiency in 50 to 100%. And we know that correction of vitamin D status increased linear growth and IGF-1 level. Reports from biochemical evidence of zinc deficiency of 40% of thalassemia patients, and those who treated patients with zinc for 1 to 7 years, they have higher growth velocity and high standard deviation score in their patients. The pathology of that causes this growth problem is not only in the pituitary. This is the pituitary gland, normal pituitary gland. This is the mild affection with decrease in the size and non-homogeneous pituitary gland because of iron deposition. This is very small atrophic pituitary gland, and this is complete disappearance of the pituitary gland by the iron deposition and atrophy of the gland. So in the MRI studies that we performed, there is evidence of iron deposition in the pituitary gland in a good number of patients with marked diminution of the size, thinning of the pituitary stalk, and sometimes posterior displacement. And this is another study, not our study, and showed the same. This is the iron deposition in the liver by MRI T2 star, and as you know, the liver is the major factory for IGF-1 generation, so it is affected. And this is the growth plate, and the iron is deposited in the growth plate, and this is another direct cause of impairment of growth in these patients. What is the effect of growth hormone therapy on growth and IGF-1 in thalassemia patients? This is 1 year study that we injected patients with growth hormone, and the response is good, but not as good as in growth hormone deficient patients. So there is some improvement of linear growth if you inject growth hormone for 1 year. And there is an increase in the IGF-1 secretion, but not to the level of treating patients with growth hormone deficiency without thalassemia. This is the 1 year study, but other authors studied more, and they injected for 2 years growth hormone, and there is a positive growth response to growth hormone during the 2nd year and during the 3rd year. Some authors studied the final effect up to the final adult height, and they found that the gain of 2 height standard deviation scores if you start early treating patients with thalassemia with short stature, the gain is about 2 standard deviation in boys and about 1.5 standard deviation scores in girls. What is the effect of bone marrow transplantation of growth on growth? Actually, this study published in pediatric hematology oncology showed that the height standard deviation score increased by 0.6 standard deviation over 5 years, and when they started the study, 40% of children were below -2, very short, but this decreased to 15% only of the children after 5 years of the bone marrow transplantation. And if you transplant patient early, they have less impairment of growth rate, and they are better for growth. The growth hormone therapy in patients with bone marrow transplantation showed that there are two groups of patients. Some of them are responders with increased growth velocity, IGF-1, and decreased ferritin, and decreased liver enzymes, and non-responders, they have decreased growth velocity, no change in IGF-1, and increased ferritin level. So in summary, patients with thalassemia, they have slow linear growth, height standard deviation score is low, growth velocity is low, especially during the late childhood and pubertal age. High prevalence of impaired and spontaneous and provoked growth hormone secretion. Low IGF-1 and binding protein 3 secretion. Low IGF-1 after growth hormone injection. They improved their growth velocity after growth hormone therapy, but not up to the level of growth hormone deficient normal children because of some resistance to the growth hormone. As I showed you, the liver is full of iron, and the deposition of iron in the growth plate, as well as some other factors as chelation therapy. There is partial improvement of final adult height with growth hormone therapy. And this is the algorithm. If you want to improve the growth of patients with thalassemia, you should not only you should improve the IGF-1 by very good transfusion therapy, improving nutrition, and actually the chelation therapy should be very tight from the early beginning, and if they are growth hormone deficient with low IGF-1, early treatment with growth hormone might improve their linear growth. Thank you very much.
Thank you very much, Professor Sullivan, for your excellent presentation. And we will leave the discussion at the end of this session.
Now it's the turn of our next session, of our next talk, Professor Alia Abdelaziz, Professor of Internal Medicine, Cairo University, on thyroid dysfunction in adult patients with beta thalassemia. Time for the talk is 20 minutes.
thyroid dysfunction in adult patients with beta thalassemia. The increase in survival rate in beta thalassemia patients lead to dramatic changes in the life requirements of these patients. And the aim nowadays is to improve the quality of life and not just to survive as in the past. Unfortunately, this leads to the appearance of new challenges that could not have been present in the past. Thyroid dysfunction is one of the most important endocrinopathy challenges, which became more and more frequent in long-term survivors and substantially affect their quality of life. طبعا disease الثايرويد متلخص بين hyperthyroid وhypothyroid. احنا mainly في our patients بيكونوا hypothyroid. ودي من manifestations الobesity طبعا والdepression والconstipation والrough skin والكلام. البوينتس اللي هو بس to be stressed في sub clinical hypothyroidism دي بتمام normal T4 and C3 مع low TSH. لكن T4 و T3 بيكونوا in the normal range. Clinical symptoms and signs are frequent, absent or non-specific. Usually found in the elderly, studies have linked T2, accelerated bone loss in postmenopausal women, a higher incidence of atrial like atrial fibrillation. Recent studies suggest an increase in cognitive impairment and all-cause mortality, especially the cardiovascular. And if patients are not treated, then careful follow-up is mandatory. The complications of hypothyroidism have complications that it may progress to other hypothyroidism. It is associated with the same cardiovascular risk like the full-blown picture of the thyroid deficiency, adverse fetal effect, and neuromuscular dysfunction. Hypothyroidism in thalassemia, the frequency is ranging between different studies between 6 to 30% among different countries, all over the world, depending on chelation regions. The hypothyroidism is primary hypothyroidism, which is mainly due to gland infiltration by iron overload. بستدي اتعملت 2010 الاوتوميون ثايرويدايتس was absent وسنترال hypothyroidism is less common. يعني mainly هي primary hypothyroidism. Due to chronic tissue hypoxia, iron overload, free radical production of reactive oxygen species, anterior pituitary damage, organ fibrosis may affect specific receptors. يعني على الأورجنز نفسهم which regulate the thyroid hormone action and convert T4 to the bioactive T3. يبقى في defect receptors ما بيقدرش يشتغل عليه. Interference induced thyroiditis in 40% of thalassemia patients with hepatitis C, which seems to be induced by interference by both immune, stimulatory, and direct toxic effects on the thyroid. عارفين طبعا كلنا الإفكت of thyroid hormones يعني very wide dose hematopoietic effect will shift the oxygen curve وcardiac skeletal lymphatic lipid metabolism pulmonary endocrine defect with effect on oxygen consumption. Regarding the cardiac, decrease in cardiac output hypothyroidism lead to decrease in cardiac output because of decrease in oxygen and substrate utilization, decrease in cardiac contractility, reduction in heart rate, increase in peripheral vascular resistance. Regarding the brain, thyroid hormones may also play a critical role in brain development in infants and in modulating brain metabolic activity in adults within our study, imaging study. It is now clear that without optimal thyroid function, mood disturbance, cognitive impairment, and other psychiatric symptoms can be. Regarding the gonadal dysfunction, subclinical hypothyroidism may be associated with gonadal dysfunction either in the male or female, interferes with their reproductive ability. The awareness of the thyroid status in any infertile couple is crucial because of its significant frequent and often reversible or preventable effect in fertility. في تالسيميا في 2012 كان عامل study عامل introduction وعامل study وقال indeed among our hypothyroid thalassemia major patients, one female with secondary amenorrhea after 5 years of combined relation, the normalization of her total body iron load and the improvement of their overall hormonal profile gave birth to 2 healthy children after normal conception. In Asian American Society of Hematology, and it seems that early administration of iron chelation is effective in preventing endocrine complications. According to the Thalassemia Clinical Research Network, that 96% of chelated thalassemia patients aged around 20 years were free of hypoparathyroidism, 91% had no thyroid disease, and 90% were free of diabetes. Overall, 62% were free of any endocrinopathy. However, this is not always the case because some patients may develop endocrine complications despite treatment. treat. Whether to treat subclinical hypothyroidism remain طبعا mainly subclinical العين. Although the course of thyroid disease in thalassemia, a major patient, is a slow process, and it might take years to progress from normal to uncompensated hypothyroidism, the decision to treat with L-thyroxine is crucial. It is particularly recommended in thalassemia major patients with cardiac dysfunction because of the potential for reducing the risk of cardiac problems. Thyroxine treatment in subclinical hypothyroidism may restore ovulatory dysfunction and adverse pregnancy outcome. The decision to treat must be individualized and based on patient's clinical history and comorbidities. Special attention has to be paid in hypothyroid children and adolescents presenting with declining growth velocity, short stature, and pubertal delay. Replacement therapy with T4 should be instilled in order to restore normal growth and development. Once growth and pubertal development are complete, thyroid hormone treatment can be discontinued and thyroid function be evaluated. After initiation of T4 therapy, the patient should be re-evaluated and serum TSH should be measured in 6 weeks and the dose adjusted accordingly. Biochemical monitoring for TSH level should be performed every 6 months to determine if retitration of the dose is necessary. As the thyroxine T4 should be taken once per day on an empty stomach, sometimes compliance is difficult to achieve considering that thalassemia major patients take many medications. Also, some of them may interfere with drug الجهدوها and may interfere with T4 absorption and should be taken several hours after the T4 dose. Additionally, a high fiber diet or coffee uptake can interfere with the absorption of T4. Don't over replace. A close monitoring of TSH is recommended in hypothyroid thalassemia major patients with cardiac dysfunction and osteoporosis and بلاش overdose. An over replacement with T4 may cause AF and accelerated bone loss with risk of fracture. دي كانت يعني very humble study عملناها في الاسم طبعا المثالي ده الكانديديت نفسه وعياد وحاجه رسلانتي من المركز القومي للبحوث والدكتور عبد الله حمدي طبعا حاجه معانا هنا. الستادي دي كانت كروس سكشن ستادي conducted on 50 adult beta thalassemia patients. المين ايج كان around 21 كانوا صوت تقريبا ميل وفيميل كان 90% منهم سبليكتومايز وال 10% كانوا نون سبليكتومايز وعلى حسب الايرن ليدون كان 50% بياخدوا ديس ديكروسامين وال 36 ديكريبول و14% كانوا بياخدوا ديكرازيروكس والسيركيليشن كان 54% كانوا ويل كليتد والتانيين كان بور كليتد والمين هيموجلوبين كان اراوند 8 والسيرم كرياتين ما كانش فارق بينهم قوي كان 2 الاسيدس اوف هايبوثايروديزم كان ايرثايرويد ستيت في 76% من الحالات وكان في هايبوثايروديزم في 22% كان سب كلينيكال هايبوثايروديزم اللي احنا قلناه وكان 2% بس اوفر هايبوثايروديزم. No cases of central hypothyroidism or cases of hyperthyroidism. الكورليشن ستادي ما كانش فيه في الكورليشن اللي احنا عملناه تي اس اتش ليفل مع اي من الديموغرافيك اللي هي الايج والويت والهايت والبودي ماس اندكس والهيموجلوبين والسي بي سي تي اس سي والبلاكليت والفيريتين كل ده ما كانش فيه significant correlation كان بس كان فيه ويك بوزيتيف correlation بين التي اس اتش والاي اس تي ليفل. وريجاردنج السيرم فيريتين برضه ما كان مع ال 3 T3 وال 3 T4 ما كانش فيه correlation فكان فيه highly significant positive correlation between serum ferritin والايزر انزيمز اللي هم الاي اس تي والاي ال تي. دي كانت ستادي معلش هو دكتور كده بس انا عمل في ايران في 2008 كانوا عملوها على 40 بيشنت with بيتا ثلاسيميا طلعوا برضه نورمال ثايرويد هرمون فاليو فاوند ان حوالي 85% ولقوا سب كلينيكال هايبوثايروديزم 15% ولقوا برضه المين فريتين ليفل بتاعهم يعني كان برضه ذا سيم وثايرويد ديسفانكشن and could not be correlated with amount of blood transfused liver function or ferritin plasma level. ودي another study هاشيمي ايتال برضه 2012 على 65 patients age برضه الرينج كان يعني 1.2 years to 27 years for all of the patients عمل لهم التي 3 والتي 4 والتي اس اتش والفريتين ليفل والريزلتس كانت 21 عندهم hypothyroidism 1.5 over hypo و 7.6 subclinical with 12 to 90 secondary hypothyroidism. وهو قال in other study prevalence hypothyroidism was ranging from 2.2 to 16.5. There was no correlation between hypothyroidism and serum creatine level. لكن طبعا recommending an annual investigation of thyroid function beginning at the age of 12 years. In conclusion, in most thalassemia major patients, there are no obvious clinical signs of hypothyroidism. So a regular follow-up for early detection and a timely replaced treatment should be implemented. The reduction of total body iron due to normal levels may play a leading role in the prevention and or reversal of hypothyroidism in thalassemia زي الستادي اللي احنا شفناها في 2012. وطبعا ان احنا بنقول ان التريتمنت ده must be individualized, فبليز forget one size fits all كلمه المفروض عفى عليها الزمن. Let us be patient centered with a clear road map. Thank you.
Thank you very much, Professor Alia, for your elaborate informative talk and for pointing our attention to a gland that's often forgotten and to show us the overlap of symptoms of anemia, depression, and hypothyroidism and the importance of correcting that. Our next speaker is again Professor Ashraf Sulaiman from Hamad Hospital, Professor of Pediatric Endocrinology, Alexandria University.
This is the second part of my talks, and it deals with the pubertal disorders in thalassemia major, which constitute a very important problem and complaint by our thalassemia patients. And delayed puberty, just some basic information. Delayed puberty, we say that the puberty is delayed in girls with no breast bearing by the age of 13 or primary amenorrhea by 15.5 to 16. And in boys, if there is no testicular growth by the age of 14 years or testicular size below 4 ml, and serum testosterone is not increasing. Hypogonadism in males we diagnosed by absence of testicular enlargement by the age of 16 years, and in females failure to progress throughout puberty or primary amenorrhea by the age of 16. And we have different types of hypogonadism. If the pituitary is not secreting the gonadotrophins, so the gonadotrophins and the testosteroids are low, this is hypogonadotrophic hypogonadism. And if the problem is in the gonads, the pituitary is normal, it is hypergonadotrophic hypogonadism. Hypogonadism manifestation before the age of puberty, small testicles and phallus, scanty pubic hair and axillary hair, disproportionately long arms and legs, and persistently high-pitched voice. After the age of puberty, small, very small or soft and shrinking testicles, loss of libido and decreased spontaneous erection or impotence, reduced muscle bulk, and reduction of seminal fluid or sperm abnormalities with reduced bone mass. And the usual investigations we do for patients with puberty, including the anthropometry, bone age, basal hormones, sex steroids, gonadotrophins, IGF-1, thyroid hormones, and some stimulation tests we might use, HCG stimulation test, gonadotrophin-releasing hormone stimulation test, and sometimes growth hormone stimulation test. With imaging of the pituitary gland might be needed. So I'll go for the pubertal problems in thalassemia. Do patients with thalassemia major have pubertal abnormalities? We have results of surveys. What is the prevalence of these abnormalities? and what is the form of hypogonadism they have, and what are their secretory dysfunction. Is it from the pituitary or from the gonads, and what's the response to therapy. The prevalence of pubertal abnormalities in patients with thalassemia is published by the TIF, and it's about 40%, and in different countries it is ranging from 30 to 70%. And even in patients with who attain some pubertal development, the age of menarche and the age of hierarchy is delayed, and the age of menarche is delayed in girls. So in conclusion, all surveys state that there is a lack of vivacity changes in a good number of patients, from 30 to 70% in boys and about 40% in girls. So what is the secretory status of their sex steroids and gonadotrophins? These are the normal secretion of age controls for the nocturnal secretion of gonadotrophin pulses in normal adolescents. And see the overnight in one of the patients. A pulsatile flat curve overnight. This is adolescent. Another flat curve or very, very minimal pulsatile release of LH. Another patient. So this is some patients have some weak small pulses overnight. So the nocturnal growth hormone secretion, spontaneous growth, LH secretion overnight is very minimal in patients with thalassemia, diagnosing the hypogonadotrophic hypogonadism in them. And if you inject the GnRH to stimulate the hypothalamic hormone, to stimulate LH and FSH, there is a defective LH secretion and FSH secretion after gonadotrophin releasing hormone. So both the pulsatile release of LH and FSH and their response to stimulation is defective. I showed you the MR studies of these patients with a lot of iron deposition in the pituitary with atrophy of the gland, almost atrophic here, because of the siderosis. So the possible causes of delayed puberty in thalassemia major the iron overload of the pituitary with pituitary damage, malnutrition, growth hormone deficiency will exaggerate the delayed puberty, hypothyroidism will exaggerate these. So, although the problem is gonadotrophin deficiency, we injected our patients with HCG, which has the LH activity. And in these patients, it's clear that 70 or more % of patients responded to HCG, the LH that we injected. But very good number of them, they didn't secrete testosterone, which means that they might have gonadal siderosis and they will not respond to HCG. So the pathology is not only in the pituitary, but also in the gonads, the testicles. What is the effect of delayed puberty on thalassemic patients? Deprivation of sex steroids after the time of expected puberty leads to loss or attenuation of pubertal growth spurt that I showed you in the previous lecture, and it leads to reduced bone mass, and we know that patients with thalassemia, they have osteopenia and osteoporosis, which will be discussed in the next lecture by Professor Eba. And testosterone as well as growth hormone IGF-1 concentrations correlate very well with the bone mass. Is iron chelation beneficial for this? Combined therapy using two chelators at the same time might induce negative iron balance, and it was shown to reverse hypogonadism in severe iron overloaded patients with thalassemia major. And chelation therapy has also been shown to be beneficial for these patients. What is the treatment of delayed puberty and hypogonadism in these patients? Depends on the many factors: the age of the patient, severity of iron overload, the associated organ dysfunction like the hepatic and heart dysfunction, presence of psychological problems resulting from the hypogonadism. For males, actually, we have two options: the testosterone and human chorionic gonadotrophin. But as I showed you before, not all patients respond to human chorionic gonadotrophins, because if they have testicular pathology, they will not respond well. Testosterone or HCG replacement increased gradually to adult dose, and puberty is normally a slow process, so you should be very careful to replace testosterone gradually. We usually start a replacement at the age of 13 and bone age of 12, and this should continue for a course of 3 years, and the effect of testosterone is significant on growth. We start with low dose, 30 to 50 milligrams intramuscularly every month, and we wait for the results. But if the patient's having hypogonadism, therapy can be continued and the dose increased to 100 milligrams per month until the growth rate wanes, and then the fully virilizing dose of 75 to 100 milligrams of testosterone depot 3 times monthly should be given. The same effect that can be achieved if you use the testosterone gel, which is not available. If the patient is asking for fertility and to test for fertility, we should, HCG is proper because some patients showed good spermatogenesis when you inject HCG twice weekly for 9 months to 1 year. The disadvantage and advantage of HCG. HCG has LH activity, so it releases testosterone from the testicle, and it virilizes the patient with increasing growth velocity and improving the bone mass. But the disadvantage is it needs to be injected frequently, twice weekly, and the advantage is that it enlarges the testicular size, and it helps to induce spermatogenesis. If you use testosterone, there is no induction of spermatogenesis, and testicles will not be growing. Some patients might need FSH in addition to HCG if HCG is not enough for induction of spermatogenesis. In girls also, estrogen replacement in girls with delayed puberty, estrogen replacement should be initiated and very gradually. And there are a lot of protocols, but they initiate replacement at the age of 12 and should be continued over 3 years gradually, and to avoid the effect of high dose of estrogen on growth rate. And this is one of the protocols to start with phenyl estradiol 2 micrograms per day for 6 months, increasing every 6 months up to 15 micrograms per day. And once you reach this dose, the breakthrough bleeding will occur, and here you might add progesterone. For achieving fertility, pulsatile treatment with GnRH in females might be used. Thank you very much.
Thank you very much, Professor Ashraf, for your excellent talk and very interesting talk.
I have the pleasure to introduce Professor Hiba Sadfi, Professor of Pediatric and Endocrinology in Shamsi University, and she has a lot of research activities and publication in the in thalassemia, the endocrine part of thalassemia. So,
Thank you. Today I'll speak about the bone manifestations in thalassemia. You can consider thalassemia as mostly a bone disease. So we can have bone affection in thalassemia if the patient is untreated because of hemoglobin deficiency, and this is the classical skull X-ray appearance. We can have obliteration of the air sinuses in the skull, the frontal, the axillary. Also, the expansion of the narrow spaces giving us the mosaic appearance in the short long bones. We can have manifestations in the ribs as a result of the medullary expansion. Again, we can have a rib and rib appearance from the, if you look here, you'll find lucency under the rib, giving the picture of the rib and rib appearance. Another manifestation of low hemoglobin and expansion of the medullary spacing is very important because I saw it a lot when I traveled in Turkish thalassemia patients, is the premature fusion of the epiphyses. We can find premature fusion in the humerus giving humerus varus deformity will cause deformity of the humerus, very short, rhizomelic shortening of the upper limb. Also in the lower limbs, premature fusion in the femur and tibia can give deformities and short limbs. In the vertebral bodies, again, we can have, of course, osteoporosis of the vertebrae, and it's a very common site for developing osteoporosis. Also, we can have the expansion of the medullary spaces can give us a bone-in-bone appearance again. Scoliosis is very common in thalassemia, with a prevalence of 20% compared to 6% in the general population. Again, we can have skeletal changes secondary to hypertransfusion. If they are given extra increased transfusion without proper chelation, we can have iron overload and hyperuricemia. Again, the chelation itself can cause bone manifestations. The metaphyseme changes attributed to deferoxamine, when they started using it early, they gave very big doses at starting at a very young age before the patient was iron overloaded, and this resulted in rickets-like manifestations at around the knees, which improved when they lowered the dose. Again, the new chelators, the very prone, can cause subchondral bone flattening, and it is one of its side effects is arthropathy. However, what we are really concerned with is osteoporosis or low bone mass in thalassemia, because most of the patients develop this pathology. Even if they are well treated, the incidence is 40 to 50% in different studies. Osteoporosis, as we all know, is the most common skeletal disorder characterized by low bone mass. There is microarchitectural deterioration, and they have susceptibility to fractures with no bone trauma. And the commonest sites are where trabecular bone is very prominent at the wrists, the hips, and the spine. And this shows us an osteoporotic fracture in a child involving both the radius and ulna. Also, they are susceptible to develop osteomalacia. In our studies, we always find that the bone affection was a combination of osteoporosis and osteomalacia. In osteomalacia, as we all know, as in rickets, there is increased unossified osteoid tissue. And the hallmark of, or the radiological hallmark of osteomalacia are the incomplete fractures of loser zones or pseudo-fractures present in the upper femur and in the scapula. We know that during puberty there is a rapid accumulation of bone mass, and we attain the peak bone mass starting in the 20s to the 30s, and then we start to lose bone mass. Because of the delayed puberty in thalassemia, again, we do not attain the peak bone mass. We find that we attain it from the 20s to the 30s, and then we start losing it with a sharp decline in women at the age of the menopause. In children and adolescents, we cannot use the same definition of osteoporosis used in adults proposed by WHO. We have to have a low bone mass in addition to a history, a very firm history of fractures, not just a low bone mass. So a clinically significant fracture history is a fracture in the lower extremity. Because in children, usually when they fracture bones, they fracture their upper extremities because of their activities. However, to fracture the lower extremity is rare. So if a child presents with a fracture in the lower extremity, it can be an alert to the possibility of osteoporosis. Vertebral compression fractures, 2 or more long bone fractures of the upper extremities. If the child sustains more than 2 fractures of the upper extremities, again, this could be osteoporosis. So, a low bone mass in children, again, we do not use the WHO criteria or the T-score. The T-score compares the bone mineral density of the patient with the mean value in young adults. That is, during the period from 20 to 30 years. That is the peak bone mass we attain. However, we compare the child with a child of a similar age and sex, and this gives us the Z-score. So this is the difference between the T-score and the Z-score. So to say that a child has a low bone mass, he has to have a Z-score less than -2 standard deviations. To say that he's osteoporotic, he has to have a low bone mass in addition to a clinically significant fracture history. And this is the T-score used in adults, which is proposed by the WHO. Osteoporosis, the bone mineral density should be less than -2.5. From -2.5 to -1 is low bone density or osteopenia, and then above -1 it's normal bone density. Also in normal children or in normal people, they fracture at there are 2 peaks for fractures. The one during childhood because of increased activity, and then when they get in elderly people because of bone fragility. This is the usual distribution of fractures. However, if you look here in thalassemia, we find that the incidence of fracture increases progressively with age because because their bones start aging at a very young age, even in childhood. Okay, so with progressive age, they start to fracture more frequently. And because the child is not so very active because he's receiving blood transfusion, he's receiving medications, the parents are very afraid to let him play, and so they don't fracture in childhood or adolescence. They start fracturing later. So the pathophysiology, as I said, of osteoporosis and thalassemia is the progressive aging of bone starting in childhood. Bone is continually renewing itself through remodeling. And the remodeling is tightly coupled, the resorption and formation are very tightly coupled, and this coupling is through the rank receptor, where the osteoblasts will stimulate recruitment of the osteoclasts. And of course we have the decoy ligand, which is the osteoprotegrin. Any disturbance in the balance between the rank and the rank ligand osteoprotegrin will result in increased bone resorption. And this is the case in thalassemia. They found it in several studies that there is an increased recruitment of osteoclasts, and so they have increased bone resorption. Again, the iron toxicity and the hypoxia and the bad nutrition are toxic to the osteoblasts. So they have a combination of low bone formation and increased bone resorption. So how can we assess bone density in thalassemia? Usually we have two modalities, the DEXA and the quantitative computed tomography. Conventional radiographs are not suitable for assessment of bone mineral density. Usually we use them just to look for fractures. And the spine fractures, by the way, we don't see a fractured vertebra. We see a decrease in height of the vertebra. And it's given different grades according to the percentage of decrease in height. So grade 1 is 25% decrease in height. Here is a very severe decrease in height of the vertebra. It's about 40%, and this is grade 2. So this is the DEXA machine. We have an X-ray source, and the patient lies on the table, and then we detect and remove.
And this is a challenging problem of